A very good morning to the chairperson, moderator, and the convener, and everyone present here. I would like to thank the AIOS for giving me an opportunity to talk on this Presbyopic LASIK, a new frontier. I have no financial interest. Defining the presbyopia, as we all know, it affects the middle age, and it is a physiological and progressive loss of accommodation affecting individuals of the middle age regardless of any underlying refractive error causing difficulty in the near vision. So what are the principles to correct presbyopia? We have the monovision, and we treat the corneas, making it multifocal or the bifocal, and increase the depth of focus. Presbyopic treatment options: lens-based procedures, corneal procedures, and sclerociliary complex modification procedures. The lens-based procedures being the multifocal IOLs, the trifocals, accommodating IOLs, EDOF lenses. Corneal procedures being the LASIK, LASIK, Presbyond, monovision, supracor, intracor, and sclerociliary complex modification procedures, scleral spacing devices. Now coming to the Presby-LASIK, it is a multifocal LASIK treatment making the cornea biaspheric. Here we make it, there will be a peripheral Presby-LASIK as well as a central Presby-LASIK, where the peripheral Presby-LASIK the central zone is corrected for the far vision, and the peripheral myopic ring is created for the near vision, and it is better for reversal. Central Presby-LASIK is more physiological because it is a central zone is corrected for the near, and the peripheral is for the distant. It is better for adaptation. Presby Max is again it's a biaspheric multifocal ablation of the cornea, making with micro monovision, and the dominant eye is focused slightly more for the distance, and the non-dominant eye for the near. Then another machine is the AIOC2022 hyperopic presbyopia multifocal approach, where it steepens the central zone for the near and leaves the periphery for the distance. What are the problems in Presby-LASIK? Is the adaptation. Neural adaptation takes time. It takes at least 3 months because of the multifocality, and patients might have night vision problems in the initial period, and also contrast changes. Coming to supracor, it is a LASIK-based procedure where both the eyes are treated for both near as well as the distance. Intracor is a flap-based, it's a flapless procedure which is not done now. It creates 5 intrastromal concentric rings between 2 and 4 millimeter to the center. It is not done these days. Coming to the Presbyond workup is Presbyond workup being detailed cycloplegic refraction and dominant eye testing. Micro monovision, we need to see whether the patient accepts the micro monovision, and regular routine pre-LASIK evaluation being the dry eye evaluation, and then the treatment is planned in the CRS master planning software. And why can't we adapt the varifocal treatments easily? That is because the brain is not wired to interpret the 2 images as one. What are the principles of Presbyond laser blended vision? We'll be making it monovision is a monovision, and also increasing the depth of focus, spherical aberrations, and neural adaptation, blur adaptation. So in Presbyond, the dominant eye is treated for the distance, and the non-dominant eye is treated for the near, and also increase the depth of focus by inducing the spherical aberrations. So what is the laser blended vision? The blend zone is the dominant eye correcting for the distance, and the non-dominant eye correcting for the near, the 2 meeting points. The 2 meeting points is the laser blended zone. So why micro monovision? It is easy to adapt. It is similar to the treatment of how the child with amblyopia behaves. The brain suppresses the image, and then the child is able to see. So it is the same principle behind this. So it is easy adaptation and more natural to our visual system. So the laser blended vision in the Presbyond, patients tolerate this better as it is not dependent on the pupil size, and a wide range of refractive error, that is around plus 5.75 to 8.5, to minus 8.5 diopters of and also astigmatism of 3 diopters can be treated. It has a very good intermediate and the near vision. The adaptability is good, and there is no significant night vision problems in contrast change. So summing up all, what is the best option? Presbyond has a better results in cases of due to the distant vision, in the intermediate vision, the near vision, night vision, the pupil adaptation and reversibility. So out of all these, comparing with the MFIOLs, corneal inlays, Presby LASIK, Supracor, and the Presbyond. So Presbyond is the best, and it has an extra edge over all the other treatment modalities. Thank you.
Okay, but what are the indications? Which type of patients you will include in case of this Presbyond or Presbyopic LASIK? What age group?
40 plus.
And suppose they are myop, would you be like to include them as well, or you will be operating only on those who are actually pre-presbyopic or hyperops?
Myopes maybe later on age group. So
but because what I've seen with the Presbyond, it doesn't work that well for the myops because they are used to have this depth perception.
Better near vision.
Yeah, so it is whenever you are starting the Presbyond, it is important that you select your cases wisely.
Yes.
And I think to go ahead, I think you should select those who have already got presbyopia of at least 1 or 1.5.
1.5.
Yeah, so that is the way to go for it. Any question from the audience? Yes.
What is the duration like? Say 4 years, 5 years down the line, we'll again. So like what 10 years?
Actually, the duration is around 5 years, but what we have seen, it works for around 7 years easily. So here you don't commit the patient, it is going to work till the lifetime or till you develop cataract. So thing is to counsel them properly. And most of them are very happy, even it was for 4 or 5 years. And it does work for 4 or 5 years, provided you are selecting the right cases. You should not operate on those who are already myopes, as I told you. And it works well. It gives you good depth of field. And whenever even they develop the cataract as well, and you are putting even a monofocal IOL, that multifocality is maintained. So that's another advantage of this Presbyond.
So when Supracor initially came, we started off doing Supracors. It almost stays for 4 to 5 years. What we do, we make the non-dominant eye myopic and this one ametropic eye. Means thinking that by around 50-52 we are planning cataract surgery for them. So we have not repeated for any patients. We have done around only 130 eyes. So maximum 4 to 5 years. We need to go with a aspheric lens which has 0 power, not to go with too much of aspheric lens for this sort of patients. And multifocal, already near focality has been created. There will be some efficacy, so preferably monofocal. That's what we have done.
Monofocal, aspheric will do. I had my aunt who underwent this Presbyond around 10 years ago, and she developed the cataract, and we operated just 2 years back, and we just put it the Technics one. It is doing wonderful. She is reading 6/6 part and N6. She is fine, absolutely. Any other questions? Yes.
It works even after the cataract surgery. So have you operated any patient who have already undergone cataract surgery and you have done this procedure for them?
Presbyond?
Yes. Who have had monofocal implanted in both eyes and then they came to you, or?
No, not yet. Okay. Because mostly what I feel, hardly you are going to get the hyperopic refractive surprise post-cataract.
Yes.
So the selection of cases, as I told you, plays an important role. It is difficult to get. I think if you have this kind of situation, it is better to go with this piggyback like Sulcoflex and all. They do have this now trifocal IOLs, which works pretty well.
Sure. Thank you.
Okay, so we move on to our next talk. That is by Dr. Anand. It is the pulse from the Femtosecond LASIK.
So good morning everyone. At the outset I would like to thank Dr. KP and AIOS for giving me this opportunity. I will be speaking on pulse of femtolasic. We have seen how the refractive surgery has evolved over last 30 years from PRK to microkeratoum LASIK to femto and to recent smile. Femtolasic is here to stay. Trans-PRK has again picked up its market share. So this is the basic idea we have all about the lasers. So when initially Femto LASIK came to the market, it was used to do the corneal incisions. So it was started marketing as by AMO as intralace. The energy increased from 15 to 60. This Femto works on a basic principle of photo disruption. It forms opaque bubble layer, very tissue specific, no thermal effect, and we call it as photo disruption. So now these days we use Smile platform to make the Femto flaps. So I'll be telling you how these Femto flaps differ from microkeratome flaps. Earlier days when intralace was there in the market, it would make a scleral based suction, so huge amount of subconjunctival hemorrhage, there was conjunctival edema. But Smile platform Femto flaps, they works on corneal platform, so you absolutely get a quiet eye with no subconjunctival hemorrhage. The advantage of Femto LASIK is you have a greater accurate flaps. You intend to make a flap of 100, you get plus or minus 10 flaps, whereas in microkeratome flaps, you will not be so much accurate. These flaps, even though if you make thin flaps, these are planar and they are very stable. All the complications which can happen with microkeratome are very less with Femto flaps. Centration is an issue with microkeratome because of cyclotorsion or manular movements. You may lose the centration, but here everything is monitored, visualized, so you can have a better centered flaps. Once you close the flap back, in microkeratome, even you can lift the flap 10 to 15 years later. We have lifted the flap for retreatment even 10 years later. But here, there will be very greater resistance to the trauma or to relift also. The IOP rise which happens during microkeratome is around 60 mm, but here with Femto it hardly goes until 30 millimeters. Whenever we do with the microkeratome, the surface can be irregular. But here, since we are making a planar flaps, the surface will be smooth, so the amount of abrasions induced just because of flap making is very, very minimal. The cut which happens with microkeratome is oblique in nature. Here it is a manual cut or 90-degree cut. The incidence of epithelial growth is very, very minimal. Coming on to the contrast, whenever the lamella anterior stroma is disturbed in an irregular way because of microkeratome, there can be reduction in contrast. Here, since it's a planar cut, the contrast is not much disturbed. So this is how in the microkeratome flaps, we can see the flap can be thinner in the center and thicker at the periphery. Here it will be of uniform size. The added advantages with Femto is we cannot place a microkeratome whenever there is a deep set eyes or prominent brow or nor or pulpal pressure. Here we are making use of a patient interface, so we can make a flaps even in this subset of anatomical abnormalities. Steep cornea, flat cornea, to prevent the complications, better not to do microkeratomes, but with Femto, yes, we can proceed. The dimensions of the microkeratome flap depends upon the K value and the corneal diameter. So we have multiple suction rings, whereas in Femto, this doesn't depend upon these two values. And as I mentioned, the standard deviation of flap thickness will be around 20 to 30 microns with microkeratome, but here accuracy is in and around 10 microns. The only disadvantage with the microkeratome flaps is the cost of the patient interface, but these days patient conversion has been very easy with even Femto flaps also. And the second toughest thing is, if at all a patient comes back with regression, to relieve the Femto flap is one of the difficult tasks. We may have to go with a surface ablation for post-Femto patients. Coming on to the complications, complications are very minimal with Femto. Sometimes due to software issue, there can be a suction loss or a severe manual movement, but even in spite of it, we can still proceed. Complications such as free partial flaps do not happen. The same entity like buttonhole can happen with Femto flaps also, what we call as vertical breakthrough. Femto always needs a transparent medium to pass through. If at all, if there are opacities in the cornea, whenever the opaque bubble layer forms, it can pass through the opacities and it can give away what we call it as vertical gas breakthrough. We might have to postpone the case. So this is how the 90-degree cut appears of the margin. And earlier days when intralace came into the picture, because of its energy setting, transient line sensitivity was an issue, but with reduction in the energy, this entity is not there with the recent Femtos. Tracking difficulties whenever the opaque layer bubble is formed, the gas bubbles can make us to feel difficulty to apply the excimer, but these two disappear within 10 to 15 minutes. We can just make the patient wait and take him for excimer ablations. So now smile is there, has taken up almost 50 to 60% of our refractive practice. Can we do everything with a smile? Yes, but there are few conditions. Even in spite of ablative smile, we still go ahead with femto. A patient asking for a wow factor, we prefer to do a femto LASIK. And whenever we do a xi-wave abrometry, if you find the trefoil or the spherical aberrations are more, I prefer to do femto LASIK rather than smile in this sort of patients. A mixed astigmatism, high cylinders, hyperopic patients, low refractive errors, rather than smile, we prefer to do a smile. Cyclotorsion is not there with smile 500, and for better astigmatism control, femto LASIK remains the best option. While doing femto LASIK, if at all if the suction is lost, still we can change the parameters, reduce the diameter, increase the thickness, and we can proceed. But in smile, in the first 15 seconds, in the first 5 seconds, if we lose the suction, we may have to depend upon the other license to proceed with the smile, or the automated software tells us to proceed with the femto LASIK. That burden of new smile has to be borne by the doctor. So most of the times we may convert the patient to femto LASIK also. And at the later stages, if you have a suction loss during the side cut, if you're not able to perform the smile, still we have to depend upon femto LASIK. Once the smile procedure is completed, you have difficulties to extract the lenticule, we have to convert the patient to femto LASIK or surface ablation. Thank you.
So you are using Visumax, right, for the femto flaps? So
Visumax.
what are the settings you use, the pack and the settings in the software itself?
I didn't get pack settings.
There are pack, small, medium and large, but I think for the Asian eyes, they only provide us the small packs.
Always yes.
Yes.
There are no incidents that we have gone with M or L most of the times.
Actually, I'm using the medium-sized cone.
Yes, sir.
When I'm treating a hypermetropic.
Correct.
When I'm treating a hypermetropic.
Yes, sir.
Once again, all depend upon the white to white.
Correct.
If white to white is less than 12, go for small. If white to white more than 12 mm, then you have to go with the medium sized, even for treating myopia.
Okay.
But for hypermetropia, you have to take little bit of risk with the medium sized cone. But the only problem is chances of suction loss is much higher in medium sized cone than the smaller size cone.
So what we are doing, sir, I am also using the Visumax to make the femto flaps. I am using the small packs, but I am using the settings on the medium cone whenever I am entering into the machine. So it gives me a good central flap, and even the area for the ablation is quite good. So that is what is suggested by the Zeiss people as well. Recently, I
Take
told
a small size cone,
yeah,
setting.
use the small size, but use the medium settings whenever you're making a flap, and it makes a huge difference. So what you said is correct. With the medium, there is a risk of that. So that is how we are avoiding it. And have you found that these flaps are slightly sticky compared to other platforms like FS200?
We have used Intralace and we have Alcon platform also. Both we use.
You have not found that. So your views? Initially, what I used to found is the flaps with the Visumax was slightly sticky.
Definitely it is sticky only.
Yeah.
But the flaps are very good. But
Yes.
sticky, as he said in his presentation. Last week, I happened to do one retreatment. The patient operated in Dubai after 27 years. But I could able to lift the flap so easily with the microkeratosis.
Yes.
But I think flaps with the Visumax, we never got a chance to lift after 10 years.
Okay.
We have to wait and see.
And sir, just to answer the previous one, you are the king of Presbyond. We all know that. So there was a question, sir. Suppose you are done the cataract surgery and patients was this Presbyond. So have you done any kind of?
Yeah, we have done for pseudophakic patients.
Okay.
Both the this one pseudophakia with a residual error of each eye around 2.5 with one cylinder, and other eye also 1.5 with the two cylinders. What I remember.
Myop or hyperop?
Myop.
Myop. Okay.
Post cataract surgery.
Okay.
And with the femto Presbyond, but the results are amazing.
Amazing. Okay. So it doesn't make a difference when the US pseudophakic.
Only thing is, if like I've been doing Presbyond from last 12 to 12 years, I think one or two patients come with cataract now. because they are diabetic and all. But these patients, I implanted a non-aspheric lens, non-aspheric monofocal lens with the non-dominant eye making myopic by 1.5 diopter.
Correct. Any other questions from the audience regarding the femtosecond LASIK? For the smile, I would say nowadays, with the correct energy settings and all, the things have quite improved. All right, so we do not get this type of problem. What you said, Dr. Anand, that the smile has some restriction, I do agree. But even the hyperopic treatment is not perfect, I feel. Even with the LASIK, it doesn't work well. And now with the Visumax 800, they are coming up with all the shortfalls they have with the Visumax 500. They are including the cyclotocin. Of course, you need the Master 700 for that, but still it is there. They are also going to release the hyperopic platform. Yes, sir.
Master 800.
Not 700.
Visumax 800, the only advantage is it is very fast.
Fast, yeah, only 8
but
seconds.
you have to look at the monitor and you have to dock it.
That's
But
the toughest part.
that is the toughest part. I do fight with the guys. But the advantage is chances of suction loss is next to zero. Because it finished the treatment by 8 seconds.
Yes.
Before fluid gushing, only the treatment part is over.
Correct.
Cyclotocin is
Yeah.
also there. And hyperopia license also
Yeah,
they are going
they
to
are
add.
going to add. So myopic treatment takes 8 seconds and hyperopic is around 14. So I think that's the way to go forward. Okay, so next we have Dr. Tushar Grover, and he'll be speaking on Target 2020, managing ups and downs of the refractive surgery.
Thank you so much for having me. Is the mic functional? Press long press करना है.
How many of you use the femtosecond platform? Come from the audience. Okay, so which platform you have? Zeiss, Visumax only. Ma'am, you? Visumax, dominant users of Visumax, I guess.
So thank you so much for having me. We've had some excellent clinical and surgical talks. Mine is on a slightly different tangent. So refractive surgery now, in most cases, you get the ideal outcome. But as we know it, you can't always do it. So how do we prepare ourselves for it, and how do we protect ourselves when that does happen? So it's important to have a thorough preoperative evaluation, set the right expectations, and then manage those unhappy patients. So starting with the thorough preoperative evaluation, there is obviously the green flags and the red flags that we're all aware about, and none of us would, operate any of those red flags. But there are some gray line areas. There is a survey which talks about how many ophthalmologists are willing to get refractive surgery. And the results are a little surprising. I mean, not many people want even laser refractive surgery, and a majority of ophthalmologists don't want lenticular refractive surgery on them. And again, a majority would definitely not get femtosecond laser assisted cataract surgery on themselves. So this is the survey. So then we also need to be aware when not to offer the surgery to our patients. Of course, thin corneas, suspect topographies here. You see you have a thin cornea, but also these changes coming up in bad D maps. You would definitely not operate on this patient. Also, sometimes we can ignore this and sometimes we do forget, but it's very important not to flatten the cornea too much, because then the patient is going to be unhappy with the visual outcomes, because there is a considerable amount of spherical aberrations induced if you either flatten the cornea too much or steepen the cornea. So sometimes good pachymetry but flat corneas, you have to say no for that reason. Extremely important to ensure refractive stability. If you have any doubt, especially in a younger patient between 18, 19, 20, be sure that there is stability. Wait for some time and then operate, because you might be in a hurry, but then you have to face that patient forever once if there is progression that happens. Uncontrolled allergic eye disease is again an absolute contraindication. These patients are at a much higher risk to develop DLK later on, especially patients who have atopy. Again, significant dry eye, anterior blepharitis, posterior blepharitis. Look for these. Do a Schirmer's in every patient preoperatively. Corneal dystrophies are often ignored as well. Sometimes we miss out, faint epithelial basement membrane dystrophy cases. So in that, obviously, you can do a PRK, but you should not be doing a LASIK. Even Fuchs. Another major cause of, post-operative complaints is because of patients having a large mesopic pupil size. So studies have shown that this is not really considered an absolute contraindication now if somebody has a large pupil size, but you must counsel that patient. You must tell them that they are likely to have glares and halos for much longer. And if you can, if the pachymetry does permit, of course, increase the optical zone as well. Uncontrolled diabetics, again, is an absolute contraindication. Somebody with Sjogren's, completely avoid, because these patients are likely to have severe ocular surface issues later on. Other autoimmune conditions where there are no ocular manifestations or they are well controlled, you can proceed. Now, it's very important to set the right expectations. We all have patients who want guarantee, who have absolutely unreasonable expectations, and you do at the end of the day have a machine, you do need an ROI to a certain extent, but you have to be careful there, because the mental discomfort that you get from these patients post-operatively, in spite of giving out the best outcomes, is probably not worth it. So try and avoid patients with absolutely unreasonable demands. Of course, counsel them well, and if they continue to have unreasonable demands or unrealistic expectations, it's best to avoid them. Then how do you manage these unhappy patients? So the most common complaints that patients have include blurred distance, blurred near vision, symptoms of dry eye, glares, halos, and night vision problems. And the most common complications you see is overcorrection happening, some amount of irregular astigmatism, dryness, regression, etc. And I will not go into the specifics of how you manage these conditions. This is something we all know of. But what is very well known and what has been found is that a majority of medical negligence claims that happen in refractive surgery are because of issues of consent. So it was only in 29% of claims where it was because of surgery being done where it was contraindicated. And though it was documented that most of the issues were not absolute contraindications and surgeries were done, there was still not enough evidence to show that patient had been alerted well enough about the fact that this is a gray area or this is a relative contraindication where the surgery is being done. So counsel well, and extremely important to document that well as well. We also are having people taking video consents these days. So especially in these gray areas where you feel that there might be issues later on, do a very thorough documentation. So thank you, and thank you so much for having me.
Excellent presentation, Dr. Tushar. My question is, so nowadays, as you said, you are taking these video consents. So are the patients being informed for the same?
Yes, so video consent we don't take in all the cases, but very specific cases where you are not sure of the post-op. And that is more often in cataract surgeries or complicated corneal surgeries. But even in refractive surgeries where you suspect there might be trouble and you are sometimes not very forward with the patient, you are not pushing for the surgery, but the patient is. So somebody who has, say, myopic macular degeneration, high myope, and the best corrected visual acuity is 612, you're planning a phakic IOL, you have explained to the patient that you don't expect too much, but you have to document that as well. So try and get that on a video consent.
Yeah. What we do at our clinic, that we have made the stamps. Suppose that there is a stamp, the patient is been explained the vision is less than 6.6, patient is explained for the regression, and we have on our own language. I am from Gujarat, so we have in Gujarati, English, and Hindi as well. Yeah. So we make a stamp, we ask him and his relative to sign over that. That is one thing we are doing, which we can easily make those stamps, and we can be on a safer side, because as you rightly said, when it comes to the legal cases, all these consents plays a huge role. So generalized consent doesn't work. It has to be, you have to mention the specific complication which can happen to this specific case. So that is the way to go forward. And what would you do? Suppose you have a previous history of patient having a viral infection and the eye is quiet for absolutely about 5 years. Would you be like to operate on those patients?
Yeah, so previous viral keratitis, etc., you do have to tell the patient very strongly again that you can always have a recurrence. So, and plus any form of laser correction can actually cause a recurrence as well. So yes, it is again, I think, not an absolute contraindication if it has been stable and there has been no recurrence for many years, but there is always the possibility. So again, I think it's the issue of the patient being well aware of what he's getting himself into.
Yeah, because we operated on a patient like this, and patient ended up having the recurrence, and it was so bad. We somehow were able to manage it, but the patient's base corrected visual acuity was reduced to 612. But that is the only case which has happened once in a blue moon. Yeah. And I think on those cases, you also have, as Dr. Tushar mentioned, the consent plays a huge role. Any other questions from the audience or from any other view? No. Okay, so
thank you.
Do we have Dr. Rajan Gupta, Dr. Kiran Kumar? Okay, then I'll be speaking next on intraoperative flap complications. Hello. Yeah. First of all, I'd like to thank Dr. Partha Biswas and Dr. KP Gudlu sir for giving me this opportunity. Not coming over there. Okay. So why do this all intraoperative flap complication needs to happen? You need to have this basic idea. So in most of the cases, is it basically due to the inadequate or poor exposure and the inadequate suction. So what are the reasons for the inadequate or the poor exposure? Suppose the patient is having a deep orbit, small eye, narrow palpebral fissure, there is a drape which comes into the place. It causes difficulty in various stages of the LASIK procedure. Many of the time there was one patient, hyperopic patient, it was so small the eyeball, I had to perform the lateral canthotomy. So I think that is the worst I have ever faced. What about the inadequate suction? We all know how can we identify there is a good suction. Whenever we are applying the suction, we should ask the patient whether patient has stopped seeing the light. That is first one and foremost good side. Then also I just slightly lift my motor and see my ring and see whether the suction is properly applied. And third way is to look on the microkeratome unit itself, where it is going to show what is the exact correct pressure. So suppose the suction is not there properly, then what can happen? Now we can have these irregular flaps, incomplete flaps. I'll be quickly showing you one of the video. Here I'm trying to make a flap with the Moria M2 microkeratome. I'm trying to make a 90 micron flap. I have marked the cornea. These were my early days. Nowadays we don't mark the corneas at all. And just see what happens. Okay, so just to go here, I've applied the suction. Suction looks quite good. Just keep a close eye over here. What happens? This is the meniscus place we're trying to win. Oops, I think there is a suction loss over here. You can see over here. All right. So there is no way this flap is completed. This is you will see here, it's an incomplete flap, irregular flap rather I would say. It is not gone beyond the pupillary margin. So here you cannot go ahead and proceed with the ablation. So what you have to do, you have to make sure that you deposit the whatever irregular flap is there back, and you deposit quite well with the Marrow-Seal sponge. Otherwise there is a risk of the epithelial ingrowth, and you don't want that. Similar thing that Dr. Anand mentioned, that it can happen even with the Femtosecond LASIK. This is the initial days when we had the intra laser, and you can see there is already suction loss, only half of the flap is made. But this is the beauty of the Femtosecond lasers, where we can always resume from the same plane using the same parameters and with the same depth only. So here we just redocked it. As you can see, these are the previous air bubbles, but they do not interfere with the final outcome. So we have again redocked it with the same settings and the same parameters. And you'll be quite amazed to see when we are lifting this flap, is absolutely smooth, crystalline stromal surface, so there is no problem. Okay, another video. These were the early days of the another keratome. And you can see this, but the motor is not going ahead over it. It is stuck over here. No matter how hard I am trying, motor is not going ahead. And now at this stage, I know that I am in a big trouble. I am not going to have a full flap. Just see, here I'm even trying to do it manually, but it's just doesn't going through. And just see over here how it is. This is an incomplete flap just beyond the pupillary margin. So here you cannot go ahead and perform the ablation. You just have to abort the procedure. So how you go ahead? Suppose you have these incomplete flaps. Suppose you have a sufficient area for the ablation. It is beyond the pupillary margin, 1 or 2 mm. Then you can reduce the optical zone from 6.5 to either 6.25 or 6 millimeter and proceed with the ablation. But suppose you end up in a situation like this, you cannot go ahead. You have to deposit the flap back. You just wait for the eyes to become quiet. You wait for around 3 months, and after that you can have the flap recut, or you can always perform the surface ablation. Okay, this is what we did. This is another video. How do we you can see over here, this is the old flap margins. You can see this is the old flap, and this is an irregular flap. Here you can see this slight scarring is there. So here what we did, we tried to make a flap which is compared to the other one, deeper one. So initially we had tried to make the 100 micron flap. So now the trick is to make a deeper flap. So here I am making a flap with 130 microns, and the trick is to make a slightly smaller flap. And just see, you will be amazed to see how easily it is being made. Many of the times what I have seen for the retreatment, these meniscus flaps perform well compared to the SBKs. Now we have shifted completely to the SBK planar flaps. And here you'll be able to see, this is absolutely fine. There is nothing you can see for the previous ones. Absolutely smooth surface. Another thing, you can even make a small flap using the Femtosecond laser platform as well. So here we are trying to make a femto. Here you can see this is the old flap margin, which is incomplete flap. Here we have made a flap which is slightly smaller and 0.5 millimeter inside. And just see, absolutely fine and smooth. The only dreaded complication I personally fear is the buttonhole. You know, it happens when the blade travels more superficially than intended and enter into the epithelial boundment complex. And it can be either a partial thickness or the full thickness. So what are the causes you need to understand for this buttonhole? Because the prevention is the best cure for this type of complication. So the basic causes are if you have an inadequate suction, you have selected the incorrect ring size. The most common which we all do is you should not reuse the blade. And suppose there is a poor quality of the blade is there. If you are using the excessive use of the anesthetic eye drops like Pentacam, you know, you are going to end up with the loose epithelium and all. This is the most common factor. And anatomical causes include the very steep corneas and irregular astigmatism. So as I told you, prevention is the best way to go forward. So as I told, please do not use the excessive anesthetic eye drops. So whenever I take my patient to the OR, suppose I am to operate right eye, I only put the anesthetic drops in the right eye. When I'm operating for the left eye, or at the time only I put it. So do not put it before, and that's my take-home message. That's like Dr. Anand mentioned, that you can also have the buttonhole in case of Femtosecond LASIK, which is known as the vertical gas breakthrough. And just observe over here. Everything looks perfect over here. We have applied the suction. And just see what will happen when we are about to complete the procedure. Just keep a close eye over this area. Suction seems good. There is a slightly smaller over here. It's one vertical gaze breakthrough. And just see over here. This about when the treatment is about to get finished, you know, I have a vertical gas breakthrough. So now what you do in this situation, as it is quite away from the pupillary area, I thought, okay, let me go through it and try to dissect it. So we went through it. I knew that the dissection in that part would be difficult. As you can see here, I'm getting the difficulty in that part only. Ultimately, what I did, I had to use the crescent blade to separate that area. I was lucky enough that it was quite away from the pupillary area, but suppose it is near the pupillary areas, then you should not proceed with this kind of dissection. You should always postpone the patient. And you can always, you know, remake the flap with the deeper cut, as I told you earlier. I was lucky enough to make it, but I do not recommend to use these ones. So how do we manage the buttonhole? Suppose they are small, peripheral, not centrally located, then you can always go ahead and finish the ablation, just like I showed you in the earlier case. But if it's a central partial thickness, then one has to, you know, avoid doing any type of ablation. You have to abort the procedure, no matter how bad you feel. And you have to make sure that you have opposed the edges well. As I told you, there is a risk of epithelial ingrowth, and this can also lead to the irregular astigmatism. So basically, the management further will depend on whether there is epithelial ingrowth or not. If there is no epithelial ingrowth, then you can safely go ahead with either PTK followed by the PRK mode, depending whether epithelial is smooth or no. And suppose you have epithelial ingrowth, then ideal way is to go forward with the PTK with the mitomycin C first, then you perform the PRK. Another complication which I would like to talk about is the free cap, which happens when you have a large and flat cornea and you have selected the wrong side of a suction ring. So how do you prevent it? So you do mark these corneas, and you keep in mind when you're operating this patient that this can happen. So just be careful and select the larger ring. So these are the various available marker. This is how we do it. So suppose you have those free flaps, you can always realign them. And this is a nomogram which we currently use for those. Suppose you have a patient who has a steep cornea 46, then I would advise you to use the ring +3 with the SOP 7.5 instead of +2 and 8. So just quickly have a look at this video. So here again you can see I have selected the ring of +2, but here I have selected the wrong ring. Ideally it should have been +1 with the stop 7.5. Just see what happens. Everything looks quite okay. I think it's not even a nasal. Whenever you apply the suction, I don't think the nasal of the sclera is seen much. But just see, nature had some other ideas in that case. Keep a close eye over here. You can see the flap is over here only, and it's a 360-degree cut free flap. So how do you manage this? Here you can safely go ahead and do the ablation. Only thing that you have to make sure that the site of this epithelium side and the stromal side is correct. So just put it aside into the desiccation chamber. You put it in the glass of the saline. But what the days I like to prefer, I just snatch it out with the forceps and put it aside over here only. Then once I finish the ablation, I carefully snatch it out and put it again back. Suppose even if you don't mark the cornea, you will have some few notches where you will be able to okay, whether this is a correct size or no. And suppose you don't know which side is the epithelium side or which side is the stromal side, then I advise you to slightly scratch on the particular side. Suppose it's an epithelium side, you'll be able to scratch it easily. That is how you can identify whether it's a epithelial side or the stromal side. Another complication which is very rare, which happened to me, it was a free flap during the femto dissection. I think this is one of the most unique complication I have come across. As you can, I've already made the flap over here. I'm trying to dissect the flap. The patient is absolutely apprehensive, anxious, and just see what happens when I'm trying to dissect. Here everything is going smoothly. I think it's going to be a very well dissect. But now suddenly patient started moving the eyes. And while I'm trying to tell him instrument is in my one hand, I'm trying to control it. But you know, there's a sudden snatchy movement of the patient. Just see over here. And what happens, my hinge suddenly becomes free. I had just look at over here. So nowadays what to do? So fortunately I had not completed the dissection. So here we converted from the superior hinge to the inferior hinge. We just dissected carefully and made sure that the inferior part of that flap is not completely separated. So this is how we had to manage. So you have to be careful. So your work job is not over unless you have done the complete dissection. So this is what we did and went ahead with the ablation. Another thing which can happen rarely is the flap decentration. If you know patient is moving the eyes, you have selected the wrong suction ring and all, but most of the time you get away with this. I think that's it. These are my intraoperative flap complication. Free to take the questions from the panelists and the audience. Yeah. Yes, I forgot to mention that. Suppose once you have placed the BCL, you ask the patient to wait into your clinic at least for 3 to 4 hours. And you make sure that everything is perfect day and night. Once 3 to 4 hours have passed, I've hardly seen these flaps are not getting displaced. I've had so far around 10 to 12 free flaps so far, and none of them has required a suture. But of course, suppose on the next day, you should see that the patient has again displaced the flap, then at that moment, you have to decide that, you know, you have to take a suture, just to be on the safer side. But usually, 99% of the time, it won't be required. And suppose you have a lost flap, then what will you do? I was able to see the flap, but suppose you have a lost flap, then your views?
Forget it and place a BCL. Localization will happen.
Yes. Correct. That's the way to go forward. Okay, so
Yeah.
So next we have Dr. Sagar. He'll be speaking on one of the most important thing for any refractive surgeon, Pentacam interpretation for the LASIK eligibility. How many of you have the Pentacam? Or I would say any tomographer? Okay, so which one you are using, sir? Cirrus. And madam, you behind? Cirrus only. Okay.
So I'm going to go to a little bit of basic the evaluation as far as the Pentacam is concerned. And I think everybody will agree with me that it's the most widely used, widely studied and widely accepted modality of pre-LASIK assessment. And it's almost become a gold standard. You know, you need to have a Pentacam fit patient to actually go for the LASIK. Now, how do you evaluate Pentacam in your busy clinic? So you may have a Pentacam or you may order it. Yeah, sorry about that. Yeah. So how do you see this? So if you're getting it done from outside or even from your center in a busy clinic, you want these 4 reports with you to make a assessment. The 4-map refractive, Bell-in-M ratio display, topometric map, and fast screening report. And you essentially would like to see these 6 points when you are evaluating a Pentacam. So let's see one by one. So the first is a 4-map refractive, and the first thing that you will see is the quality score. So if it's okay, you would proceed to evaluate it. If it shows yellow, that means there are data gaps, you need to repeat the procedure. So that's the first thing that you will do. And the next important thing is pachymetric map. Pachymetric map essentially will give you 2 things. It will give you a map, which will basically give you point-wise representation of the corneal thickness. And on the left side, you will get what is the dimensions of the 3 important parameters. That is the thinnest local, pachy apex, and pachy at the central most point of the pupil. So here the important point is the thinnest local. So if you have a thinnest local of less than 417, then obviously this patient would not proceed with a refractive surgery. And if it's between 470 to 500, we can consider a PRK if the other parameters are normal. The other thing that we will know is the difference between pachy apex and thinnest local. It should be less than 10 microns. And the next important point is noting the vertical displacement of the thinnest local. And if it is more than 0.5, as can be seen from this thing, you definitely this will contribute a red flag. The other thing that you can see is the difference between superior and inferior corneal thickness. If it is more than 30, then it's a red flag. So these are in short the pointers which will tell you what abnormalities can happen, which you need to look for. Elevation is the most important graph in Pentacam, and basically what it does is basically it gives you elevation values at the anterior corneal surface and then the posterior corneal surface. And how does it do it? It basically, the machine takes out data from the 8 millimeter diameter and it makes up a best fit sphere, which is then put across the anterior surface. The areas which are above the best fit sphere are basically shown as steep areas or warm colors, giving a positive sign, and the areas which are below are given as negative or flat. So just look at this. So here is the anterior, the front elevation, and this is the back elevation. So you can see clearly there is +5, +7. So these are the areas which are above the reference surface, and on the back side you have around +12. So any anterior elevation above 8, posterior elevation above 17, and any point where the anterior posterior elevation difference is more than 5, it's significant. And very important is to look for any isolated islands. You can clearly see there is an isolated island. This also should be a pointer that something wrong is happening. Another important parameter which has come off late is the thinnest point. So what you see is a circle here. The thinnest elevation at that point on the front and the back. If anything is above 5 on the front and above 12 on the back, then this is a significant. Next is the sagittal curvature. I think we all are aware of sagittal curvature, but what parameters we need to look at are these. So you have the flat K, because you want to know the flat K as to how much we can do the correction. So every 1 diopter of myopia, you are basically inducing a 0.8 K fattening. We don't want to go below 34. K2 will give you steep K, so basically you don't want to go beyond 49, 50. Then you have mean K, because anything below 40 will have a risk of free cap, more than 46 will have a risk of buttonhole. And K max, anything beyond 48 is a red flag. The difference between 2 K max between the 2 eyes should be less than 2 diopters, and difference between K max and the steep K in the same eye should be less than 1 diopter. So this is another important point wherein you basically get color representation of the sagittal curvature. IS difference of it should be less than 1.5, and SI difference should be less than 2.5. It also gives you shape. These are symmetrical shapes, or you can have asymmetrical shapes which actually can show pointers towards the different types of ectasias. Like here you see a pellucid marginal degeneration, here you see a keratoconus. Then you need to look at the skewing in case of astigmatic bow tie astigmatism. So if there is a skewing, the tilting of one of the lobes, if it is more than 22 degrees, as can be seen in this thing, then it is abnormal. So these are the important points that you have to remember when you're looking at the sagittal curvature. And the fifth point is the Bell-in-M ratio map, which basically should be viewed in these 4 points. So we'll go one by one. So basically, Bell-in-M ratio ectasia map creates a new best fit sphere by excluding 3.5 to 4 millimeter of area around the thinnest point on the cornea. And what it does, it creates a new reference surface which is flatter than the original reference surface. As a result, the ectatic areas get enhanced. So if you can see clearly that we compare this to this, this has become flatter and this area has got exposed more. So how do you apply it clinically? So this is the patient's original elevations. Now when you apply the Bellin-Sem ratio new reference surface, you can see clearly that the ectasia has got enhanced. Now what is the difference between these two? We get it in the difference map. So anything beyond 7 microns in the right on the anterior and beyond 16 microns in the posterior becomes significant. So next is the thickness profile map. Basically, you have about 22 concentric circles which are drawn across the thinnest point on the cornea, and the pachymetric measurements is done from the thinnest point to the outermost version, and basically you get a graph. So you get 3 dashed lines. The middle line is basically the normal population's value, and the the superior and inferior basically shows 95% confidence interval. The red line is patient's values. So usually it should fall between these two lines and it should follow the curve. And the percentage thickness index increase is essentially the same thing in the form of a percentage. So here you can see an abnormal shape where there is a quick slope where it dips before the 6 millimeter zone. So definitely there is a fast thinning that is happening here. The point which I was telling you, the thinnest point elevation, this values you can get it from here. Then there is something called as Pachy progression index, how fast the progression happens. There is an index to that. Anything beyond 1.1 is abnormal. Then there is something called as ART max, which is also an important parameter which is there. But most important is these 5 deviations which are actually taken out from all the values that we have just discussed, and it will label it as white if it is less than 1.6 standard deviation from the normal population. It labels it as yellow if it is 1.6 beyond 1.6 to 2.6, and red if it is more than 2.6. But the most important here is the final D, which is a global parameter which will encompass all the individual parameters, and the guidelines which Dr. Bellin, who is the inventor of this thing, is clearly mentioned here. So try to stick to these guidelines. If you are doing LASIK, of course, if you are doing PRK, the guidelines are a little more liberal. And the last is basically topometric map, wherein you look for this indices, and you don't have to remember the values. The machine itself will flag it as white, yellow, or red. And this is a fast screening report. I would suggest that this should be seen at the last, because by the time you have evaluated all these parameters, this gives you a very good look. The horizontal bar is basically the distribution of the normal population, and it is at one standard deviation, 2 standard deviation. So where does the patient's value sit in that graph is what it gives you. So this is how you go ahead and do a systematic evaluation of a Pentacam, right from the first map to the last map. And believe me, it takes about 5 to 7 minutes to go through all this in a systematic way. It's very difficult. Then it's very unlikely that you will miss anything abnormal out of this evaluation. So thank you.
Excellent presentation. In the positive term, you have tried to cover almost all the topics. But one thing I would like to add up, that Pentacam still is not a perfect unit. Whatever indices you showed, like the pachymetric progression index is there, whenever you say the curve dips, they all have been taken account by having the Western data in mind. So suppose you have everything normal, you have a normal curvature, and suppose your pachymetry is around 500, and if that curve is dipping, it doesn't mean that the patient is abnormal. So you can also do it. So what is important here, like you mentioned, is to see the shape in the axial curve. That is the first and foremost sign where you can quickly pick up whether there is a skewing or no, whether there is inferior stiffening or no, whether there is a skewing of more than 30 degree or no. I think those play important factor rather than believing in all these indices. Again, the ART max and all, they have been all made using these Western data. So don't follow them blindly. That is my take-home message to all of you.
Western data is there, but we have Indian data also from Dr. Shetty's group. It has been published in AGO.
Just last 2 weeks before we had Dr. Shetty, we were blessed to have him, and he himself suggested that you just don't follow it blindly. Instead, you just see the patient as a whole. And another important thing is, when you have this 4-map refractive and we have this thinnest location, you click on that and you draw a square over there. And all those 4 points are coinciding, then yes, definitely your patient is at trouble. But what you said is right. Whenever you're following in your early days, yes, you have to follow this. But once you are above that, you need to see the patient as a whole rather than blindly believing in those indices. Any views of you, Dr. Manpreet?
Yeah, of course, I think we should always make a habit of correlating clinically. And nowadays, we have newer modalities. We are taking biomechanics into account. We have Corvus, etc. So in toto, I think you can, and it's better to be safe than sorry. The borderline cases, rather avoid than think if you can go ahead with surgery in that or not.
And I think Pentacam also gives you a lot of false positive. Suppose the patient's white to white is less than 11.4. So if it is between 10.9 or 11.4, then you are going to end up having a lot of these elevation points on the balloon as well. So again, you have to keep a close eye whenever you take a Pentacam reading. You have to keep a close eye over the white to white as well. Any other questions? Yes, sir.
So like patient is on contact lens or has dryness, how long do we wait before doing, like I don't have a Pentacam, I refer to another center. So how much, like how long do we treat and when we repeat, like?
I think for a soft contact lens, 1 week to 10 days is enough. But if it's an RGP, probably 2 to 3 weeks would be an ideal time for the corneal shape to come back.
Correct. And suppose you are feeling that the patient is having slightly dry eyes, then once you ask the patient to remove the contact lenses and start them on the lubricants, and it works well in case of the soft contact lenses. Any other view?
Yeah, I think we follow the same dictum, a week to 10 days and 2 to 3 weeks for RGP.
So I think a lot of patients come for screening on a day where they've just worn contact lenses.
Yeah.
So I do kind of screen them on that day.
True,
If it's
true.
absolutely normal, I schedule them for surgery, but I do repeat the Pentacam on the day of surgery to make
Correct,
sure
correct.
everything is normal.
I think that's what we all do. And that is the right way to go forward. Do not operate them on the same day. That is a take-home message. You should wait.
Plus also if you tell them we are not screening you today, you come back after.
Yeah.
They won't come back.
Yeah.
Yeah.
Dr. Anand, you had question? Correct. Yes.
70% and sensitive around by 90%. So we
Correct.
should be very cautious.
Yes.
Slightly
So the
overestimate.
question is whether it differentiates normal from keratoconus or normal from subclinical keratoconus. So from differentiation from normal to keratoconus, it's very clear. It differentiates very nicely. The problem is in the
Middle
gray
one.
zone,
I
in
think
the gray
that's the
zone.
one
So
we
that's
all
where
are
you
having
need a
trouble.
combination of those parameters. One parameter doesn't work out well. You need a combination.
Yeah, so nowadays you need this epithelial mapping, I think, to, as rightly mentioned by Dr. Anand, you do have a lot of false positives with the Pentacam. So I think epithelial mapping and stromal elevation is the way to go forward. But they are very costly machines, I guess. The one is made by the CSO MS39 and it costs almost 90 lakhs with the taxes. So I think we all may not be able to afford it, but what we can do, we can have this thing in mind, all those shapes like Dr. Tushar had showed to us, whether this is a normal bow tie, this is a symmetry bow tie, asymmetry bow tie, superior skewing, inferior skewing. That is the first image you should have in your mind whenever you're trying to go for the refractive surgery. Any other questions, or we move on to the next speaker? Okay, so our next speaker would be Dr. Manpreet Kaur, and she'll be speaking on challenging situations in SMILE. And I think it's an important topic because we all want to end up smiling after spending a lot of money and not having an unhappy patient.
So, though this photo looks like a smile, the patient was definitely not smiling in this one. So, I'll be covering the challenging situations in SMILE. I have no financial disclosures. So, as we all know, LASIK, we follow the dictum of see one, do one, and teach one. For SMILE, it does not really hold true. There is a significant learning curve with the majority of complications occurring in the initial few cases. Lenticule dissection and extraction being the most challenging step. This is our documentation of the learning curve. What we observed was that it decreases from 16% in the initial few cases to only 2% of complications in the next 50 cases. So the learning curve, though steep, does decrease over time. So suction loss, black spots, opaque bubble layer, cap lenticular adhesion, retained lenticule, cap and side cut tears may be observed. Suction loss is basically due to the inherent soft docking in which the cornea is accurvated rather than applanated, and it's a low pressure suction cone with only 35 millimeter mercury of pressure. So the incidence of suction loss ranges from 0.8 to 4.4% and can be as high as 11% for novice surgeons, further compounded by an uncooperative patient, deep set eyes et al. So now we have algorithms on how to manage suction loss based on the stage at which the suction loss occurs. First, you have to identify the underlying cause and the stage. So if it occurs at less than 10% of the lenticule cut, you just redock and restart the procedure. The problem is when it occurs at more than 10% of the lenticule cut, then you have to abandon the procedure and convert to a surface ablation or LASIK at same sitting or later date. Lenticule side cut, or cap side cut. Now we have the rescue mode in the machine itself. You can redock and restart from the point at which suction loss occurred by just decreasing changing the parameters slightly, decrease the lenticule diameter and the cap diameter respectively. Then coming to the main complication during lenticle dissection and extraction, difficult lenticle dissection and cap lenticular adhesion is the major issue. Conventionally, we dissect the anterior plane first, then the posterior plane. Novice surgeons, of course, may have difficulty in identifying the posterior plane as well, especially in thin lenticules. If you dissect the posterior plane first, you end up with a cap lenticular adhesion in which since there is no posterior stromal support anymore, the lenticle is stuck to the overlying cap. Going anterior and trying to dissect it from the cap does become difficult, and you can have a host of complications including retained lenticule, delayed visual recovery, cap and side cut tears, posterior stromal damage, epithelial defect, and irregular astigmatism. So we have described the use of anterior segment OCT as a rescue tool during difficult lenticle extraction in SMILE, because what is the major issue is you don't really know, are you in the wrong plane or not. So ASOCT helps to identify that here the posterior plane is well delineated. You can see the whitish hyperreflective line, and anterior plane is not that well delineated because it's not been dissected as of now. So the lenticule is stuck to the overlying cap. There is localized posterior stromal damage where we have been trying to forcefully find the posterior plane posterior to the original lenticule cut. And so then you just go in with the Sinski or reverse Sinski and nudge the lenticule from the overlying cap. You see a meniscus shaped gap over here, and that helps you to confirm that okay, the lenticule is stuck to the cap, and then you can go in with a dissector. The free dissection, initially we found it difficult, so we just sort of peeled it off from the overlying cap from both sides and then extracted it with a forceps. So this is one of my cases in which we had a cap lenticular adhesion. With experience, of course, we became more confident in handling it. So I'm just going in with the reverse side of the dissector and just peeling off the lenticule from the overlying cap, coming till the site of the cap side cut, and then once there is an anterior plane created, I'll just go in with the dissector anterior to this, and yeah. So the subsequent dissection is not very challenging once you know what you have done and what you are supposed to now how to handle it. And in fact, in this case, I could extract the lenticule without using a forceps, and the dissection was almost as smooth as a primary case in which you go anterior first and then posterior. So most important is identifying the issue and how to handle it. You have to identify the lenticule edge, that's most important. This is another case in which there was a increased opaque bubble layer and black spots, so there's a difficult adhesion. So we went in with the forceps and tried to extract the lenticule. However, it was not completely separated from the peripheral adhesions, or what we had was a retained lenticule, a torn lenticule with retained lenticule fragments. So you should always, in challenging cases, examine your lenticule to see if you have left any piece. And once you have a retained fragment, it causes irregular astigmatism, blurred vision, and customized surface ablation may be planned at a later date, but this irregular astigmatism does become challenging to manage. Now, double concentric edge separation has been described by us to manage cap lenticular adhesion, in which once the lenticule is stuck to the overlying cap, you can go in with the same maneuver that I described from both edges and then separate the lenticule till the midline from both sides so that the side cut tear does not extend and you do not end up with cap tear. Otherwise, this peeling of the lenticule does lead to smile shaped side cut incisions as I showed in my first slide. Then we have described a stepwise management algorithm for difficult identification of the correct dissection plane in SMILE. So cap and side cut tears can be seen in 0.3 to 16.2% cases, and side cut extension and tears are much more common than they have been reported. Related to surgeon inexperience, the bulky instrument hub, we are so focused on the leading edge of the instrument that we forget that the hub entangles in the site of the cap side cut and can lead to tears and extensions. Excessive surgical manipulations, sudden patient movements, and small incision size also predisposes. So always start with the larger incision, a 4 mm maybe, and then go to 2 mm as your experience increases. So this is a cap side cut tear, and this of course is a side cut extension and tear. And so a bandage contact lens usually suffices. So patient selection and is of course important for the initial few cases. Go for thicker lenticules, moderate to high refractive error rather than going for 1 to 2 diopters initially. Avoid deep set eyes and uncooperative patient. We have described meniscus sign to identify the lenticule edge in SMILE. So this is initially to help prevent a cap lenticular adhesion and a lenticle misdissection. So if you see this frilled edge and the instrument is above it, then that means you are in the anterior plane. If it's below that, it means you are in the posterior plane. Microscope integrated OCT has emerged as a useful tool. However, it is as of now not integrated in the SMILE machine, so it is a bit cumbersome to shift OTs. Just to sum up, the initial learning curve of SMILE, of course, is surgically challenging. During femtosecond laser application, you may have suction loss, black spots, opaque bubble layer. During lenticle dissection, you can have misdissection, cap and side cut tears, and retained lenticule. Prevention, of course, is better than cure. Complications are inevitable, and timely detection and management give both the patient and surgeon a reason to smile. These are our work, a book on SMILE as well as current concepts in refractive surgery. You can go through them. And I would like to acknowledge my mentor and guide, Professor Jeevan S. Dityal. Thank you for a patient hearing.
Excellent presentation, Dr. Manpreet. Any questions from the audience? Okay, just to add on, suppose you don't have you don't end up with this rolled lenticule. I think the trick is whenever you are separating the anterior lenticule, not to separate it fully, you leave the 3/4 of it.
During posterior, we leave the attached edges at the opposite edge and the 3 and 6.
Yeah, 3/4 of the anterior
yeah.
on the opposite. And whenever you are entering from the posterior, you just start separating from the opposite side. I think that is the trick.
No, anteriorly we dissect fully. While we are dissecting the posterior, we leave some adhesion so
Okay.
that the lenticule does not fold.
Okay.
And those remnant adhesions are released last when you're trying to extract.
Okay. What we are doing is exactly opposite.
Okay.
We are separating the anterior first, 3/4 only. We are
Yeah.
leaving 1/4 of the section. Then while we are entering into the posterior plane, we are just starting to separate it from the opposite direction. Once it is done completely, then we sweep it like this, so that the rest of the 1/4 of the portion also comes out with there. So what
Okay.
this, I don't have to put the extra instrument inside the eyes.
Yeah,
That is the
yeah,
forceps. So
yeah.
many of the time it is the one which is causing the extension.
Yes, true.
So the lenticle edge separate just comes out from the incision side, and you
Yeah.
can easily pick it up. That is what we are doing.
Yeah.
And I think SMILE is the way to go forward. Would you agree?
Yeah, of course.
And what about the biomechanics? But nowadays the people are saying that the biomechanics of the SMILE and the LASIK both are same initially, which was claimed that the SMILE is a better biomechanics. Your views on that?
Yeah, ectasia has been reported after SMILE as well, and we do not have our personal long-term data. As of now, in our cases, we have not observed any ectasia, but just clinically also, when you observe post-op cases of SMILE after LASIK, you can always see the interface and those fine striae. In SMILE, if you don't search for the cap side cut, you can't even say the patient has had a surgery. It's so clean after a point of
Yes,
time.
but many of the times we do not have this wow factor in the SMILE. So what can we do to have the wow
I
factor?
think with experience that wow factor does come.
I think another thing is the ironing of the Bowman's membrane, which is the most important thing. Whenever you remove the lenticule, you just hydrate the wound and you do the Bowman membrane. Doesn't matter it is a spatula or a sponge, but it is must. And I think with the correct energy settings, you need to know your machines well.
Yeah, of course.
So the
That's
dissection should be
imperative.
smooth, and once you have done that well, I think we have this wow factor. Initially, we were troubling, our energy settings were quite high. It was around
Yeah.
30, 31, and now we are on 23,
Okay.
and it's working absolutely fantastic. So, do we have our next speaker, Dr. Kiran? So, Dr. Kiran will be speaking on combined topo-guided PRK with CXL in keratoconus. How many of you are doing SMILE from the audience? Okay.
Good morning, everyone. Yeah, I'll be discussing on topo-guided photorefractive keratectomy with collagen cross-linking in cases of progressive keratoconus. As we all know, like KC is a progressive bilateral asymmetric ectatic disease with irregular astigmatism and visual deterioration. But the thing, is it clear now? Yeah. And as we all know, like collagen cross-linking is the only procedure as of now we have been practicing in our clinical practice to stop the progression of keratoconus. Keratoconus is characterized by steepening, and there's a lot of irregular astigmatism. And to tackle this progression of the keratoconus, so we have only one procedure, that is CXL. If we do CXL, it just stabilizes or flattens the cornea, and the results are usually totally unpredictable. Some cases responds very well by causing flattening of about 2 to 4 diopters, but some cases really fail to respond. And because of that, corneal irregularity still persists, and definitely there will be poor BCVA, and some cases may even have scarring. So they usually get up to like 6.9 to 6.6 with rose scale lenses. So what is a CXL plus? When CXL combined with refractive procedures, as you all know, like CXL only gives anatomical stability for the cornea, but the functional results are usually poor. That usually takes almost like 3 to 6 months for them to advise for any other vision correction procedures. So there is something called Topo-guided PRK or PTK, and even with Intacs we can manage this. What does it do? Like Topo-guided PRK, it actually flattens the cone of the peak, so thereby it flattening and it broadens the cone. So the total biomechanical strain will be redistributed on the cornea. So definitely at the end of 3 months they'll have a better uncorrected visual acuity, and definitely the best corrected visual acuity. Our preferred practice criteria is like we usually consider this procedure for the progressive keratoconus. We have to repeat Pentacam at least in a 3 months interval, and if there is any progression noted, we can plan for this procedure. Expected corneal thickness at the apex of the cone after PRK with epithelium, it should be at least 350 microns, and there should be clear central cornea, and ideally it works better for central cones. And maximum ablation, till now Canalopolis has done the cases till up to 50 microns, but in our series we have corrected up to 80 to 100 microns. But our basic thing is like we should have at least 350 microns at the end of the procedure, and optical zone can be considered from 5.5 to 6.5, because if we keep more optical zone, more tissue will be ablated. So ideally the 6 is my optical zone which I usually consider. And target refraction, it's never undercorrect, never hyperopia, because that will be very bad for the patient. This is basically based on a refractive coordinated system which is provided by the Zeiss, which has MEL 90 and it and Atlas topographer with CRS master, and planning will be done accordingly. What do we do actually? This is not based on our Pentacam values. This is a Placido disc based device, is Atlas topographer, where we capture the anterior segment image and we will plan. That software will be, so that software helps us to transfer the data directly to CRS master. This is a planning station. Here we have to do our like subjective planning. The main things we have to enter is like pachymetry, which is usually the preferred values in the literature is 450, but we do consider doing from 400 to 450 as well. So this is a pachy apex, and the manifest refraction. Usually keratoconus patients in advanced or moderate cases, they will be associated with very high irregular astigmatism, but we cannot correct all. So we target usually to correct most of the cylinder, so that spherical can be better tolerated with spectacles in post-operative period. And optical zone we usually consider for 6 millimeter. And here we have 3 options in this platform. One is the first one is topography guided. That's what we are doing. That's called Athens protocol. And the topography smooth. Topography smooth is a software which just regularizes your cornea. It's like flattening the speed brakes on the road, so that they'll have better curvature on the anterior surface, and there is standard spilocylindrical correction. So this gives a 3D image of the patient's cornea actually, that I'll show later. If you see this case, he has a central slightly superior cone here with keratometry of about 52. So what we do, this is basically like dependent on our subjective refraction. A very good refraction has to be done to confirm the axis, otherwise it will ablate in a different axis, and that will be more trouble. So what we have to do, we have to ablate this region of the cornea, and this will be our exact ablation pattern, and it can be represented by 3D also, like what we are doing. This is the pre-op photo. With this ablation, we had experience about 30 years with follow-up of almost 2 years. At 1 year, mean uncorrected visual acuity improved from 0.5 to 0.4, and BCVA improved from 0.42 to 0.23, and 28 eyes gained 2 or more lines of uncorrected visual acuity post-procedure by 6 months. The mean keratometry were reduced by almost like 1.7 diopters and 2.18 respectively, and Kmax up to like 4 to 5 diopters have been flattened. This is one such case. He had almost like a central cone with moderate. This is a case which I had shown as a workup. He had thickness of only 429 with maximum keratometry of 58, and he had cylinder of about -6. We will be correcting here only -3, because if you see here, he had a thickness of 429, so we can ablate up to only 54 microns in this case. So we have residual of at least 375. So This is a pre-op ablation pattern. When we are planning only, it shows like how do we, this is the cone, and this is our ablation pattern, which if you see it's like completely there'll be flattening of the cone. This is post procedure at the end of 1 year. The cone is totally flattened. You can actually see the comparative video here. So this is the follow-up result of this patient, almost like a 1.5 year follow-up. We had a K1 of 52, which was reduced to 51.4, and K2 of 55.7, the drastic reduction of about 3.4 diopters, and astigmatism is also corrected up to 2.2 diopters. So definitely with the advent of technologies and more better platforms, management of keratoconus is taking a next seat. I think this is one of the best option which we can do to give an uncorrected best visual acuity even for keratoconic patients. And few of our patients even have 6 6s uncorrected at 6 months follow-up as well.
Which riboflavin you use normally?
See, it depends on whether my criteria is without epithelium. If thickness is more than 400 or less than 400, we go for hypotonic. If it is less than 400, if it's more than 400, we'll go for isotonic.
And how will you remove the epithelium? Your preferred way?
No, only with alcohol.
With alcohol?
Yeah.
Because alcohol with Topo-guided CXL.
Yeah. And
causes
one
haze.
more thing, I even do use mitomycin C. My preferred protocol is I do it for 10 seconds for every diopter. Yeah, they will have certain pain, that's okay, but at the end of the 6 months, they'll be very much happy.
Usually what we use is isotonic one and the 0.25 or 0.22% riboflavin normally. That is what is
that's the
advised.
normal thing. Yeah. See, there are two things here, whether you have to use Dextron or HPMC. But Dextron, if you use, they will be hygroscopic it is, so thickness will further reduce. So it is always better to use HPMC preparation.
And how long you irradiate?
Yeah,
UV
irradiate,
light?
it's usually accelerated protocol. And our one more protocol is coming up. It's for adapted fluence for the thickness of less than 350. We have our own calculator. It's in the review for the publication. So we are recommending it soon in the cornea.
Any other questions from the audience?
In this case, for example, the limiting factor was that you can ablate only 50 microns. So I would probably prefer reducing the optical zone to 5 and being able to remove more cylinder.
Yeah,
because
definitely.
As it was a central cone, you can always do that.
Yeah. And one more thing, that's what our usual, this is one of such case. In the beginning, I just wanted to show that because we don't know the results, long-term results. There is only one paper published by Canale Police, and I think they had done only some 10 cases. That was a retrospective case. And this series, we are still trying it, and longest follow-up is almost 3 years now. And all are stable, none of them are progressed with spectacle corrected vision, not contact lenses. Yeah, that's around 64 cases.
So, but this works good for the central cones, I guess.
And one more thing is there he has corrected maximum of 50 microns, and he has done resident protocol there. And here, that is one more thing. He has not touched any eyes which is less than 400 microns.
So just to sum up, you are using the alcohol to remove the epithelium. Then you are using the hypotonic riboflavin, PESK-H.
Depending on the thickness.
Yeah, depending on the thickness, of course. Or without Dextron, the PESK-M and all. That is the one you use. And you irradiate accelerated one or the conventional one? Accelerated one. What are the energy settings? Can you sum?
9 milliwatts for 10 minutes.
Okay, that's the way. All right, and what about the inferior cone? Suppose you have inferior cone, then does it work well?
Yeah, usually we try to ablate or whatever we do in the central 7 millimeter. It usually doesn't work much for inferior cones. At least it should have been in central 5 millimeter is most ideal, what I'd say, instead of 3 millimeter. See,
good result.
It just regularizes speed breaker on the roads, no? It smoothens. Otherwise, if there are inferior cones, you can go for the other nomogram, that is Topo Smooth. It just regularizes your entire cornea from whatever, if you take 7 or 8 millimeter, it just regularizes up to 20 to 30 microns.
Because nowadays, there is a lot of talk going for the track, but that is only exclusive to the SWIN platform, where even if you have a decentered core, inferior cone, you can only ablate a particular area. Ablation is limited to that. You can do it Topo-guided.
Even
it is not with any other machine apart from the SWIN.
No. Actually, we are in talk with the Zeiss. Even this platform provides that. Zeiss only has not published the data still.
I'm using Zeiss since 2012. I don't think they have it yet.
They have it. Yeah.
Exactly.
Yeah.
Okay.
This is like combination of both topo-guided as well as subjective refraction. If you really do subjective refraction with topo-guided, it will definitely hit on your cone only.
Okay.
Yeah.
So I think it's a good modality that we can offer some kind of refractive
Definitely.
correction to our keratoconus patients.
Yeah.
Exactly. VCTVA improves.
BCA, it always improves, and most of the people definitely won't be like willing to spend so much for rose scale lenses. It's very costly. So
I
we can
agree.
better accept it with the normal soft lenses only.
All right. Any other questions from the audience? Or we end the session? All right. So it was nice having all of you. Thank you very much for your patience. Looking forward to see you all next year. Thank you.